Good afternoon, everybody. We are going to initiate our first meeting of the year of the Acute Flaccid Myelitis Working Group. Should say thank you very much to our colleagues in Europe that are late in the day and are joining us. The same for our colleagues in Africa and Latin America who are joining today. This is a working group that is focused on acute flaccid myelitis and enterovirus and myelitis in general, with the plan to coordinate any effort in outbreaks, patient diagnosis, care, and research in acute flaccid myelitis. This afternoon, we are going to have a very interesting program that is going to discuss the 2022 paradox, the enterovirus circulation without AFM. Appreciate very much the participation of our colleagues at the CDC who are going to provide an update about AFM and enterovirus circulation. I thank you very much to our colleagues in Europe, Dr. Harvala, Fisher, Benchop, Simons, and everybody in Europe, Dr. Elferic in Netherlands, who are going to provide an update from the European situation. And also to our colleague, Dr. Ria Mustafa, who is going to provide an update about enterovirus circulation and sequencing in Maryland. And at the end, we will have Drs. Brian Greenfield and Dan Park from Princeton University, who are going to provide us with a very good overview and modeling of enterovirus circulation.
Let me just share my screen. I'm Sarah Kidd. I'm glad to have my colleague Heidi Moline, who's going to be sharing this presentation with me, and she will discuss some of the EVD68 data. So let me bring these up. Are these visible now, Carlos?
Perfect.
Can you see these? Okay, great. Thanks for having us. So I'm starting off with a slide that I showed back in our November meeting. So just reminding us where we were. Our first signal in the United States was first detected in August last year when we were receiving reports of increased pediatric hospitalizations for children who had rhinovirus, enterovirus positive severe respiratory illness. And when not all of those are typed routinely in the United States, but when those were, there were a handful that were EVD68 positive. And so that was the first signal that CDC had that we were starting to see EVD68 severe respiratory illness, a peak year in the United States. And currently, at the same time, CDC, through our National Respiratory and Enterovirus Surveillance System, or NERVS, saw an increase in RVEV positive respiratory specimens in that system. And then also through the New Vaccine Surveillance Network, there was noted an increase in EVD68 detections among children with acute respiratory illness. Notably, all 7 sites of the New Vaccine Surveillance Network had an EVD68, at least one EVD68 detection from April to August in 2022. And the number of detections between July and August at that time were greater than at the same period during previous years. So those were all reasons for concern. And as a result, CDC released a health advisory that about the increase in severe respiratory illness associated with rhinovirus and enteroviruses, including EVD68. This was released at the first week in September. And a main messaging of this was just to report what we have been observing and hearing from around the United States, but also to be on the lookout for cases of acute flaccid myelitis, what to look out for, and instructions about how to the initial management and specimen collection for those cases. So we were on alert for AFM at that time. And this figure shows the number of reports that we receive of possible AFM cases that are reported to the CDC by week of the year. So in blue is the average that we have seen during the peak years for AFM, which were this 2016 and 2018. The yellow line is showing the what we saw for reports in 2021, which was an off year, and then in red was what we observed in 2022. So you can see at week 35 here, which is at the beginning of September or mid-September, we did see an increase in reports, and so we really thought we were starting to see a peak AFM year. However, that subsided, and we kind of returned back to baseline in terms of reporting. So those are reports. Those are not confirmed cases. This is our epi curve to date, showing that we didn't see an increase in confirmed cases either. So to date for 2022, we have confirmed 44 cases in 24 states. There were no EVD68 detections among the confirmed cases in 2022. We did, however, have 2 confirmed cases with EVA71 detection in stool. So again, no confirmed AFM cases, no confirmed AFM cases had EVD68 detections as far as we're aware. So that's the picture of AFM. I'm going to pass it off to Heidi Moline. Heidi, I have your slides teed up here, but you're welcome to share yourself. Just let me know.
This is great. Thanks, Sarah. To provide a little bit more context to what we were seeing last year with EVD68 for viral detections. First, the new vaccine surveillance network, for folks that are less familiar, is really what we use at CDC to actively detect EVD68. We operate in 7 pediatric hospitals and conduct active respiratory surveillance for multiple pathogens. So what we see here is, and we've been doing surveillance since 2016, but really since 2017, we've had pretty standard surveillance across all of our sites. All but 2 sites first test for RV-EV, and then for any positives, they test for EVD68. 2 sites actually test all samples for acute respiratory illness year-round for EVD68. So just to provide a little bit of context to these surveillance data. And what we can see here is this last year, we had a large amount of ARI. We had a lot of RSV circulating at that time, and a flu season as well. So just to put that into context for why the ARI numbers look as elevated as they are. And what's important, I think, here is the percent of EVD68 positive among all children with ARI. And so we're closest really to what we saw in 2018, at least within our surveillance network for this. And then when we look just at the RV-EV positive, we're really reflecting that 20 to 25% that we were seeing back in 2018. So again, these are for children tested that are under 18. But it really showed that our year last year from a detection standpoint within our network was very similar to what we saw in 2018 when we did have our large amount of AFM cases. Next slide. And for just to show what our epi curve looked like, again, this is a geographically diverse network. So we have a West Coast site, we have several East Coast sites in the United States. But we had kind of an early bump at 2 of our southern sites in Houston and Nashville. And then the rest of the network really started seeing more cases with up to that higher percent positivity in August. And in the first week of September actually was the highest rate percent positivity within our network. So again, this is just to show that that we have kind of a classic epi curve with an early EVD68 or early fall enterovirus season. Next slide. And this got crunched a little, but what I just wanted to show that we're a network that has other viruses as well. And this was this was a rough respiratory season for us in the United States. And to note that RV-EV really started early in the fall for us and was followed very quickly by RSV and influenza. And so again, that points to the ARI season, but that RV-EV and EVD68 really contributing to this large percent positivity that we were seeing for RV-EV in the early fall months. So with that, I'll pass it to Sarah.
Thanks. So that's all we have. I think I'm interested to see what others have to present. I know we're all wondering why, the explanation why there was this dissociation between EVD68 this year and AFM, and we really don't know. I think there are a few hypotheses that, some may be more likely than others, but I know one that we're exploring is the virus somehow different in 2022 than it was in previous years? So far, we don't have any suggestion of that. The sequencing that we've done is showing that all of the ones from 2022 are clade B3, except for one that was a clade D. And that is similar to what was seen in 2018, which was predominantly clade B3 as well. And then, could there be some cofactor that was protective in 2022? For instance, are multiple viral infections at the same time, respiratory infections, somehow contributing to some added protection of invasion or severe EVD68 disease? Again, these are just hypotheses. I'm not sure what we have data to support any of these, or was there some cofactor that was present in previous even years during our peak years that was somehow absent in 2022? So I think these are all things that we just need to keep an open mind about and think as we go forward. But I'm interested to hear what everybody else says. So thank you.
Thank you, Sarah, very much for that presentation. And you outlined very well the questions that we are going to be discussing in the next few minutes after the report from Europe, as well as the sequencing and Brian presentation as well. In the chat by Matt Elric, were EV subtypes other than 871 detected among the other confirmed AFM cases, or were these largely cases that failed to capture EV-RV positivity? Adriana expanded the answer, but I like that you described to the group what you think.
Yeah, we always see, of those that are EV-RV positive, we always see a real variety of types because a lot of this is from respiratory specimens. So we do see a lot of rhinoviruses that we think are just incidental, concurrent upper respiratory infections. We also, I can't remember specifically for 2022, but we frequently see Coxsackie viruses. Echovirus 11 is another relatively highly ranked virus that we see often. But EVA 71 is notable just because we know it has been linked to AFM in previous years as well.